Hi, everyone. Happy to introduce Dr. David Quan to our bi-monthly meetings talking about issues related to spinal cord injury. He's going to be talking about psychological effects of spinal cord injury. David, take it away.
All right. Thanks, Dr. Abramoff. So the topic I chose, as you can see, psychological effects of spinal cord injury, was really prompted to look more into this based off of kind of a difficult patient case we had a couple weeks ago. As some of you might recall, just like a patient who became very withdrawn after his injury, just made it very difficult to, really participate in therapy and whatnot. And that kind of just sort of prompted me to want to learn more about this topic and sort of just share what I learned with everyone here. So just to start off, why is this an important topic? Why would we care? Certainly, I think the number one thing is just simply the prevalence in the spinal cord injury population. I think if you've spent really kind of any time working with these patients, you'll start to see that a lot of them do exhibit signs of anxiety and depression, and it can certainly have a profound impact on them, not only in the acute rehab setting, but certainly, many months to years afterwards. Poor functional outcomes, we obviously care about that as we work in inpatient rehab, but I think just this makes a lot of intuitive sense. A lot of these patients, because of just how they're feeling and their mood, will oftentimes decline working with therapy, and obviously that that would lead to sort of just poor improvement in terms of their strength and their ADLs. There are some studies on this. A VA study recently did show that there was some association with sort of depression scales and also sort of distances that patients were able to perform in their wheelchair. So there does seem to be some sort of correlation between the two, and I think that, again, makes intuitive sense. And then lastly, just overall increased morbidity and mortality. And again, I've sort of listed some factors there, but self-neglect is really can be really detrimental in this population. As we know, patients with spinal cord injury require really close care and consistent care in terms of all their different needs, whether it's bowel or bladder, wound care, and a lot of the onus sometimes comes down to the patient themselves to kind of advocate for that. And if they're severely depressed, that can be a huge obstacle to their long-term health. Rates of alcohol and drug abuse are much higher in the spinal cord injury population, and also rates of suicide. So, I've seen studies that kind of generally estimate the risk in the SCI population for suicide is up to 3 times greater than in the general population. And they also note that the highest rate of suicide is approximately 1 year after injury. So that's also something to keep in mind as well. All right. So moving on, just to dive more into this idea of prevalence, to kind of get some numbers here. So a 2015 meta-analysis that sort of collected data from 35,000 different subjects from 19 different studies showed there was about a mean prevalence of 22.2% that is depression in the SCI population. And just of note, most of these subjects were men, which kind of matches with what we know as the general demographics of SCI. Mean age 23 to 66. And so this important number is 22%, and that's compared to the sort of general prevalence of major depression in adults in the US, and that's reported to be around 7 to 8%. So in comparison, you can see that the rate here for SCI patients, certainly a much higher proportion of them kind of deal with depressive symptoms. So now I'll kind of go into just what the, what's the course of sort of the psychological course that these patients take, from the very beginning in the immediate acute phase of their injury. So, I think this is still an area that isn't super well defined or studied, but in general, patients immediately following their spinal cord injury, so like in just the first few days of like their acute hospitalization, many of them have difficulty sort of coming to terms or realizing fully the significance of their injury and sort of the implications it might have for the rest of their life. And there's a lot of different factors for that. I have some listed here. So first, effects of medication. These patients are coming out of major surgery. They have effects of anesthesia, pain medications, and that's going to make it really difficult for them to sort of have, that's going to limit their understanding. Sensory deprivation from the injury. Pain is obviously huge in the acute setting. So all of these things make it really difficult for these patients in that kind of initial period to really understand what's happened to them, and that can really affect their adjustment and their coping. And then there's also a significant proportion of patients that are conscious during their injury or their accident, and many of them, and I've seen statistics again, 40 to 50% say that they were immediately aware of their paralysis. Like they immediately felt that they, weren't able to, move their limbs or whatnot, and that can be a very traumatic moment for them as well. And I'll speak more later about sort of PTSD in this population. So generally, again, in this acute phase, as they're sort of coming to grips and coming to terms with this huge life change, psychologists have kind of termed that initial period as a stress reaction. And that's obviously not unique to just spinal cord injury. It's really, any kind of like intense, huge life change can trigger this. And it's defined as sort of just a period of intense emotional turmoil. Some of these emotions I have listed here. Denial is obviously at the forefront. Numbness, disbelief, anger, fear, hope, despair. And I think a lot of us see patients here who might exhibit a few of these emotions on a day-to-day basis, or maybe all of them. And this kind of stress reaction, has been sort of, there's like kind of different schools of thought in terms of what this stress reaction really should be viewed as. It can be viewed as sort of maybe an abnormal behavior, a defense mechanism against extreme life change, or it could be viewed as sort of a normal, necessary part of this sort of lifelong process of readjustment. But either way, it's definitely something that happens, and something that I think a lot of us here do see even in the rehab setting. And then, of course, something to keep in mind as well is just that the spinal cord injury population is like so varied, so different, whether it's age, level of injury, socioeconomic class, and education, and that all of those things are going to come into play when it comes to what a patient's reaction is going to be and how well they cope to this huge life change. And then I'll sort of delve a little bit deeper into the later course, so beyond acute rehab. There have been some studies that follow up with patients sort of up to a year and beyond after spinal cord injury. So this one I have here is a 2016 cohort study following 168 patients. They were interviewed at different intervals up to a year post SCI. And you see here kind of on the bottom, it seems like the most common response psychologically is just sort of stable, low severity depression. And that's just based on, again, like sort of questionnaires and scales that they did. And then a smaller minority, about 30%, were in this moderate severity depression group, and they were also fairly stable up to a year. And finally, you have this much smaller minority of severely depressed people who kind of reported sort of an increase near a year of their depressive symptoms. And again, I think two things to note. Again, like it seems like a year out is usually when the risk of suicide is most high. And then another thing these authors note is that generally these patients in the moderate to severe groups had some sort of pre-morbid diagnosis of anxiety or depression even before the injury. So that was another association that they found as well. Then I think it's also just important to note that there have been also other studies up to 5 years, up to 5-year follow-up that did find 18 to 20% of participants with probable major depression. So, I think it makes sense that, given SCI is a lifelong injury, that a lot of these sort of psychological effects are indeed, also lifelong. So next, I'll kind of go into some contributing factors. I think a lot of these make just intuitive sense, so I won't spend too much time. Pain is obviously huge in the spinal cord population. Almost every patient deals with it to some degree. Medications, a lot of them, again, are on different kinds of analgesics, anti-spastic medications that can affect their mood and cognitive function. Medical complications such as like pressure sores, autonomic dysfunction, things that kind of limit their own independence, can contribute to depression. Self-image is a huge one. A lot of patients, or a lot of people, I think, independence is a huge part of who they are and their own self-worth and self-image. And when that's lost, that can be truly like psychologically traumatic. Something that I think, even I've heard a lot from these patients is, this isn't me. So I think that's definitely reflective of sort of our reality here. Cognitive problems, again, this is well documented. Spinal cord injury is definitely well associated with traumatic brain injury, drug abuse, all sorts of, even sleep apnea is something that affects cognition and is very common in this population. And then again, I touched on this before, sort of comorbid psych disorders. People who've had anxiety and depression before the injury are likely to have a more severe course of it after the injury. And then, of course, a lot of these patients get their injury in very traumatic, life-threatening events. So, it makes sense that the incidence of PTSD is going to be much higher in this population as well. And then finally, in terms of like factors, contributing factors, I'll touch a little bit upon sort of, some ongoing research in the physiology of depression in the SCI population. It basically boils down to uncontrolled inflammation. So, this is the sort of hypothalamic pituitary axis that we know, where the normally you have this basically negative feedback loop where, once the hypothalamus acts on the adrenal gland to stimulate cortisol, that cortisol will eventually come back and sort of will limit the further kind of feedback into this loop. But in spinal cord injury, you have basically an increase of pro-inflammatory cytokines and also dysregulation of the gut microbiome that research has shown that basically continues this increased inflammatory state, and that definitely has effects on the brain and on depression and anxiety as well. I'll get into some protective factors now. Age and sex, I think there's a lot of like conflicting research on right now. Some studies say that like old age is protective. Some say like young people can cope better with SCI. So it is a little bit unclear. In terms of sex, same thing. I think there's conflicting evidence here. I saw a study in the VA that said women have higher rates of depression after SCI and endorse more depressive symptoms. So I couldn't really find a good consensus there. However, I think these last few are definitely more well supported. This idea of like different personalities with like locus of control. So in general, people who have this internal locus of control, feeling like they have a lot of ownership in their own health and their life and their situation, tend to sort of do better psychologically. Whereas people who sort of have like this kind of outlook where, you know, their life isn't under their control, they don't have any control of their life, sort of have this kind of helplessness for whatever reason, tend to have are associated with sort of you know, worse psychological outcomes. Social support is huge. I think we all sort of know this intuitively as well. People who have good family support, support from friends, that's going to be a huge buffer to psychological trauma, and really just you know, these patients do a lot better later on, not just psychologically, but in general as well. And I think there's a lot of good evidence that supports that. And speaking of which, this is a paper that actually Dr. Johnson brought to my attention that kind of sort of supports that thesis, so or that theory. So this was a paper, just very briefly, that basically followed I think about 200 patients, spinal cord patients that also had chronic pain. And they basically did sort of a cluster analysis of different characteristics of this group, of this cohort of 200 patients. And they were able to sort of group these patients into 3 subgroups. The first subgroup was kind of, they called them like basically a dysfunctional subgroup. They had high pain, high life interference, high emotional distress. There was a second group called interpersonally supported, meaning they also had moderate to high pain severity, but they felt like they had higher life control and they weren't in as much emotional distress. The third group was sort of people who were doing actually pretty well, low pain, low life interference from their injury, low distress. But I think the thing that was so interesting is that in comparing the first 2 groups that had similar levels of pain severity, the main difference between their sort of their reported life satisfaction was sort of their perceived social support. So it's interesting that there seems to be some pretty strongly supported evidence of like an interplay between social support actually alleviating kind of self-perceived impact of pain and of the injury, if that makes sense. All right, and then finally here I have just interventions for this population. You know, obviously medication is something that we're all well aware of. SSRIs, antidepressants, venlafaxine in particular is something that's been well studied in the spinal cord population. It kind of has like a 2-pronged effect with both depression and also pain. Counseling is something that's very commonly used just to enhance this idea of like self-responsibility, self-control in this population. Again, support groups, that plays into this idea of social support as a protective factor. And then finally, cognitive behavioral therapy or psychotherapy. This actually is probably the most well-studied and most like evidence-based in terms of helping patients kind of treat their anxiety and depression. Especially this idea of activity scheduling. It's like an exercise where patients are asked to sort of plan out activities that they can master and have a sense of sort of like, again, yeah, like a sense of mastery over. And that also sort of increases their self-efficacy, which is really important for these patients. So that's really about it for my presentation. I just have some like conclusions here, some takeaways. There's an elevated risk of depression and suicide in the SCI population. It's definitely an important issue. You know, depression in this population is influenced by a lot of different factors, psychosocially and also biologically. Patients with premorbid mood disorders, premorbid anxiety and depression generally are at risk for a much higher severity of anxiety and depression after their injury. And then social support is super important. Again, acts as a buffer from from trauma and from big life changes, and is associated with improved outcomes. And yeah, like I said, cognitive behavioral therapy is probably one of the better supported ways to treat depression in this population. But that's it. If anyone has any questions or comments.
Excellent job, David. This is Nora. I have just a couple of things that I'd like to add, or one thing to comment on. I thought that it was an extremely good synopsis. Kudos. So on your last page there, when you mentioned premorbid mood disorders affecting the outcomes, of course, that is so true. But, you know, the premorbid mood disorders also affect people getting into these situations, taking risks. So, yes, the men account for something like 80% of the SCI injuries, of total injuries, but it's also people who are willing to take, as you've said, greater risk. Mood disorder fits into that. It promotes that. It kind of deadens for a lot of people a caution, so that they would act more rashly. Does that come across as making sense to people?
Yeah.
Okay. And then the only other thing that I want to say is, as with our patient in question, interesting data point is that the average, the mean age of the SCI person is now about 40 years old, whereas it used to be younger. So it's aging. That average age is moving up, which is an interesting statistic.
Yeah, something to consider. Thank you.
Yeah, thank you.
I had a question.
Yeah.
You mentioned the CBT that is particularly helpful for spinal cord injury patients, like the activity planning and that kind of thing.
Yeah.
Did you come across anything about the efficacy of SSRIs in spinal cord patients? Is there much of a benefit given that a lot of the depression is has a focus?
Yeah. Claudia, our med student's asking if there's if we came across anything about SSRIs, particularly in the SCI population. I think if I recall, there was a review, a paper that I saw where SSRIs had kind of a class B or C recommendation. I don't think it's something that is proven to be any less effective than in sort of the general population. I just think that it seems like the research shows that CBT again is the preferred first line if possible. But yeah, I mean, just based on personal experience, I think a lot of these spinal cord injury patients do end up on SSRIs. I don't know if Dr. Abramoff can speak more on this too, in his experience.
Yeah, I mean, we tend to like to use a lot of these patients have either issues with insomnia, there's issues with pain. So if we can get some 2-for-1 benefit, that's usually preferred. There are some possible benefits to SSRIs in neurorecovery, although that's very limited and more in kind of animal models. The other things I'd want to add is, keep in mind substance use and substance abuse, very common in spinal cord injured patients, both leading to their injuries and also, causing post-injury behavioral issues and depression and anxiety and things like that. And also think about the medications you're ordering. CNS depressants, gabapentin, opiates, all those things can have an effect on mood. So, always think about what can we do to kind of, before just medicating things, avoid these issues.
Right.
I'd like to address the CBT, cognitive behavioral statement. Actually, the reason that it comes out as a preferred approach is because the overwhelming number of studies have been done using CBT. It's actually not a preferred approach. So that as studies come out comparing different approaches, they're all about equal. So it's more of how the therapist approaches it and what's the relationship, as what we call it, therapeutic alliance between the therapist and the patient. So CBT gets lots of claim and credit for something that you have to look very closely at. It's really not a preferred approach and often doesn't work for people with SCI or with other things. So
what approach do you recommend?
I don't recommend a particular. So again, I'm going to say it's about that therapeutic alliance between the patient and so I usually look at the patient and try to weed out what is this patient going to respond to. Do they want psychodynamic? Do they want CBT? Do they want emotionally focused? Do they want solutions focused? You know, a whole host of different types of therapies, but you have to fit the person, the patient to the therapy and vice versa. And it might be a combination of various therapies as well.
Thank you.
Interesting. Yep.
Does anyone have any other questions? Well, thank you again, Dr. Quan, and we appreciate you sharing this very important topic for our patients with spinal cord injury.
Yep. Thank you.
Good job, David.
Thanks.